So here's how the evening program will flow. After Dr. Choe lecture, we will open up the floor to question. If there's any person here in person, please wait until the microphone is presented to you before you ask your question, so everyone can hear, including those who are joining us via Zoom. For those in Zoom attendees, feel free to type your question into the chat box and we'll share them during the Q&A section. Once all the questions have been answered, we conclude the lecture portion of the meeting and end the Zoom session. Those attending in person are invited to stay with us and enjoy some refreshments, and we will then continue with our support group meetings. So it's now my pleasure to introduce Dr. David Choe, a distinguished cardiologist at Eisenhower. He specializes in diagnosis and treatment of cardiovascular disease and is deeply committed to advanced heart through the patient care, education, and innovation. This evening, Dr. Choe will be speaking on the diagnosis of coronary artery disease, offering valuable insight into the latest approaches of technologies used to detect and manage the common yet serious condition. Please join me in welcoming Dr. Choe.
I've been here for 11 years, almost exactly. I started, I signed on November 1st in 2014. And then I started seeing patients on November 10th. So it's been almost exactly 11 years now that I've been here. And our mission has always been to keep the residents of the Coachella Valley's hearts as healthy as possible and to keep people alive and healthy. And when I joined this group of cardiologists that I joined had that mission in mind, and they were doing an excellent job. And so I feel privileged to be part of this group of cardiologists here. Plus, they've been a really nice group of cardiologists, and I think that speaks for the Valley. Everybody here, it's been very nice, and so it's been a privilege of living in the Coachella Valley for the last 11 years, maybe except for that heat in the summer. The problem with coronary artery disease is you've probably heard this many times. You've heard of patients going to see their doctor, and the next day they get a heart attack, and they're in the hospital and they're getting a stent or a bypass surgery. And even to the very best of cardiologists, that occurs because there is no test that will tell us that somebody is having an impending heart attack in the next day or 10 days or 6 months or a year. And so yeah, I almost feel like an insurance agent when I'm talking about coronary artery disease, because it's about risk assessment and risk reduction. Because we look at the population as a whole, and we're trying to prevent heart attacks as a population in a whole. But it's very tough to actually pin down when somebody's going to have a heart attack. But if somebody does have a heart attack, it's very obvious. Their cardiac enzymes start going up, and they feel so poorly that they call 911 and go to the hospital. And when you're in the hospital, you get diagnosed with a heart attack, and you get a stent or a bypass, and then you get placed on medications. People tell you you have to eat healthy, exercise, and do all the healthy stuff. And so that's coronary artery disease. But we're trying to figure out who is at risk of having a heart attack before that. And sometimes we cannot predict it. And a lot of the times that happens. People just come to the hospital and all of a sudden you're diagnosed with coronary artery disease. But we're trying to get a little bit of a peek into what somebody's risk is and can they have coronary artery disease. And it's not a perfect science. That's the thing about medicine is it's not perfect. Nobody presents exactly the same. And so we're here to talk about different types of tests to try to figure out whether we have a heart issue or not. And so the heart is a pump. The heart has a plumbing system, and the heart has an electrical system. And all of that helps the heart move blood around the body. And so we have the human body here, and the oxygen is picked up in the lungs, goes into this red part of the heart, and then it gets pumped out into this aorta. The aorta looks like a candy cane. It starts going up and then comes down and then goes down into the legs, and then it divides once it gets down towards the legs. And then there's some branches up on top. And so this is on the right. There's a magnified view of the heart, and these are the different chambers of the heart, and this is all trying to pump blood to the body. Now, the main pump is called the left ventricle. And so this pump has the biggest muscle. The muscle is about 1 centimeter in thickness normally. It could vary, but it's the thickest part, and that's where people have heart attacks, is in this muscle. And so if this muscle dies because there's a lack of oxygen, that's what heart attack. And that lack of oxygen is coronary artery disease. And the reason why we call it coronary artery disease is because there's these little arteries that come out. And so if there's ever a Jeopardy question as to what the first artery that comes off of the aorta is, the answer is, what is the coronary arteries? Because right below here is the big pump, that left ventricle, and this is the aortic valve. And when the heart pumps, when it squeezes, the valve opens, and this is that valve again, the aortic valve, and right in the cusp of these valves is the two coronary arteries that comes off, the left coronary artery and the right coronary artery. And so these coronary arteries come off so closely to the heart that it's almost part of the heart, but it comes off and then it descends back down into the heart, and then it feeds into the muscle of the heart. So the coronary arteries, it comes off, the left one and the right one, and then it starts branching. And so when we do angiogram, when we image it, it looks like a root of a tree. There's all these branches, and then it keeps on branching until it gets so tiny, and then those tiny arteries go into the muscle, and it feeds blood into the muscle. So in order for this muscle called the heart pumps 100,000 times a day. It's been doing that since we've all been born, and it really doesn't skip a beat. It can do that for 100 years or more for some people. And so this muscle requires oxygen, and the oxygen is through these coronary arteries. So that oxygenated blood, the blood with oxygen, gets pumped out of the left ventricle, and a little bit, like less than 10%, gets branched into the coronary arteries, and then it comes back into the muscle, the left ventricle, and then it feeds the muscle to keep on pumping. The rest of the blood, the 95% of the blood that goes out feeds the rest of the body. It feeds the brain, eyes, liver, stomach, muscles, everything else. But these are the coronaries, and that's why it's called coronary artery disease. Coronary artery disease is a disease of these small little arteries that track back down into the left ventricle and feed oxygen into the left ventricle. So One thing that we think about is this thing called metabolic equivalence in cardiology. So the definition of one metabolic equivalent is when you're doing completely nothing, like you guys sitting here in a seat, not doing anything. That's considered the amount of energy that the whole body is requiring is considered one metabolic equivalent. And the reason why we think about that is because the body has a huge overcapacity. We're not all sitting all the time. We're doing different things. And so, for example, when you're walking at 4 miles per hour, a brisk walk, you increase that heart's capacity to pump by 5 times. So you're needing to supply all your muscles, and so the heart, instead of pumping 5 liters per minute, it 5 times that. It's pumping 25 liters a minute. And it can do more. When you're running at 6 miles per hour, you're going 9.8 metabolic equivalents. So the heart's pumping 10 times the amount of blood that it usually does with you just sitting here. So the body has this vast over capacity that it uses when you're exercising. And somebody like LeBron James, they're probably at their peak, they're probably going at about 30 metabolic equivalents. They're pumping a lot of blood out. You know, like those cyclists that are doing going up those Alps. Tour de France, that's right. And so going up those mountains, they're probably doing 30 metabolic equivalents. Isn't that amazing? So the heart's pumping 30 times more than at rest, which means it needs to circle back back to that muscle again. So the muscles in our body is using 30 times more, but that pump is using 30 times more oxygen. And so our body has a huge overcapacity. A few, so we'll have a few examples, other examples of metabolic equivalents. And so light gardening, light cleaning, washing dishes, putting away groceries, walking at 2 miles per hour, that's about 2 to 3 metabolic equivalents. We can all do that. But then we get to a little bit more exertion, like scrubbing the floor, gardening, salsa, dancing. That's like 4 to 5 metabolic equivalents. And then walking 3 miles per hour up 3% grade, a 3% grade is like 5.3 metabolic equivalents. Walking and golfing is 5.3 metabolic equivalents. Biking is 5.8 metabolic equivalents. And then there's things that require more metabolic equivalents, such as hiking, backpacking, sparring, climbing stairs. And then it starts going up from 6 metabolic equivalents up to 8. Swimming is 8.3. So having intense swimming is 8.3 metabolic equivalents. Rollerblading, biking at 15 miles per hour, soccer, about 10 metabolic equivalents, breaststroke, 10 metabolic equivalents, martial arts, 10 metabolic equivalents, jump roping, rowing, biking at 17 to 18 miles per hour, running fast, like a 7-minute mile, or rollerblading at 13 miles per hour plus, that's 11 to 12 metabolic equivalents. So our body is able to do a lot. And why is this important? Because when we do a stress test, we cardiologists, we measure it as metabolic equivalents. So the first stage that we do, we're already at 5 metabolic equivalents. This test was not made for the weak. Actually, this protocol, this is a standard protocol that we've been using since like the 50s for a very long time. And it was first made for naval recruits. So the metabolic equivalence goes up pretty quickly, 5 to 6.8. And most of it is not the miles per hour. Most of it is the incline. So we just start putting in a lot of incline, and that pretty much increases the metabolic equivalence. And we get to 22 metabolic equivalents by 18 to 21 minutes. So this is me. This is my beautiful wife. This was 14 years ago. I ran the marathon, the LA Marathon. The only marathon that I ran was 14 years ago. It was a feat. I won't say how long it took because it took a long time. But I was probably in the best shape that I was. And so this was during my cardiology fellowship that I ran the marathon. And one Thanksgiving, our VA chief cardiologist, Dr. Foster, he says, even though we don't have any patients scheduled on the day after Thanksgiving, you all have to come in and work on the day after Thanksgiving. And so we tried to argue ourselves out of it, but we could not. We had to come in. And we had nothing to do that day. So I told myself, you know what? I'm going to do this Bruce protocol. I'm going to try to beat it. I'm going to try to get to the 21-minute mark. And I did. But what I had to do was I had to hold on to that bar, and my legs were running faster than I could have possibly ran. And I hit 22 Mets. But after I was done, I was dizzy and I was diaphoretic. I was not feeling good. So I started drinking water. I was like, okay, I need to get a lot of water and to get myself to feel better. And about an hour and a half later, I didn't feel too much better, maybe a little bit better. So I went down to the cafeteria and I bought myself a Coca-Cola and I drank a Coca-Cola and I felt much better. But getting to 22 Mets is tough. We usually ended at like stage 3, 9.4 Mets or so. Some people can make it longer, but it takes a lot of energy to get up, and getting to 22 Mets is quite difficult. I probably won't be able to do it now. And so the issue is we're looking into the coronary arteries, and the coronary arteries are not like PVC pipes. It's not like a little hairball clog in the middle of the PVC pipe. The problem is on the walls, there's cholesterol plaque that starts to form. And so this cholesterol plaque starts to form, and it starts to impede the amount of oxygen. And so that's what we're looking for. Now, this is a graph of coronary flow reserve. So, we talked about people that can run 22 Mets. Well, what we're showing is at one metabolic equivalent, depending on the amount of coronary artery narrowing there is, even if there's about 50% blockage in a coronary artery at rest, you're still getting flow, perfect flow, because we have this overcapacity. And then even at rest, at one metabolic equivalent, you can get to probably about 80%, and you're still having almost normal flow. So at rest, somebody could be having an 80% blockage, and they still have normal flow if you're just sitting and doing nothing. Now, when we increase our metabolic equivalents and we need more flow, then we start having more problems. But even at a higher flow, even with the blockage at 50%, we have almost normal flow. That's just how our body's been made. And so we can actually probably get to about 70, 80%, and we'll still feel decent. but then we'll start having chest pain at some point in time once the amount of flow starts dropping in the coronary arteries. So this is the problem with doing a stress test is people with 50% blockage, they will pass a stress test with flying colors. And so that's why when we say, oh, somebody has a 50% blockage in their coronary arteries, cardiologists don't even bat an eye. They're like, oh, they don't need a stent. Why do they not need stents? Because they have normal flow in the coronary arteries because we have this overcapacity. So there's no need to put in stents and we can live a completely normal life. And so when we see like a 50% blockage in an angiogram, we say, oh no, they don't need a stent or a bypass. They just need to be put on heart medications, eat healthy, and exercise. It sounds very counterintuitive, but that's the answer. And it's because our body has so much of an overcapacity. And this is not like a PVC pipe. Even with the 70-80% blockage, we can live a perfectly normal life. So, but what we're looking for is the possibility of heart attacks into the future, and we'll get to that. So, what is angina? There's this word called angina, and um, a week ago, there was an article that said the dictionary.com word of the year in 2025 is 6'7". You guys will only know if you have 7 and 10-year-old daughters like me at home. Yeah, this is like a elementary junior high school thing. And you have to go like this, 6'7". And I looked it up. There's actually no definition for 6'7". That's the answer is there's no definition for 6'7". Anyways, but the dictionary.com definition of angina is a syndrome characterized by paroxysmal constricting pain below the sternum, most easily precipitated by exertion or excitement, and caused by ischemia of the heart muscle, usually due to coronary artery disease as atherosclerosis. And this is that 70-80% deal that we're talking about. Like, because of this overcapacity, people feel perfectly fine when they're not doing anything. And as you start increasing the amount of exertion, you get angina. But this is not a cardiology definition of angina. We have a more specific definition of angina, and there's actually 3 parts to angina. So what's the cardiology definition of angina? It's 3 things. Substernal chest pain. Number 2, brought on by exertion. And number 3, relieved by rest or with nitroglycerin. And so if you have all 3, we consider that typical angina. If you have 2 of those 3, we call that atypical angina. And if you have 1 of those 3, we call it non-anginal chest pain. Why is this important? Because back in 1979, in the New England Journal of Medicine, 2 doctors from Cedars-Sinai, Diamond and Forrester, came up with this what we call now a Diamond and Forrester pretest probability chart. And so everything is sort of based on this and stress tests. But when you look at this Diamond and Forrester chart, what we only have 3 things that we classify with chest pain. One is the definition of angina. So on top here, we have typical, atypical, non-anginal, and asymptomatic. And then we group it by age, by decades, and then we do it by gender, male or female. And so if you have typical chest pain, so those 3 definitions, That's substernal with exertion, relieved by rest and nitroglycerin. And if you're 60 to 69 years old and if you're a male, you have a high pre-test probability that it's coronary artery disease. And what do we mean by high? High indicates greater than 90% chance. And then low is less than 10%, and intermediate is 11 to 89%. That's how we classify it. But if you have a typical angina, and if you're 69, male or female, it's high. And then it starts becoming a little bit better. But if you look at this red, there's very little categories where it's low pre-test probabilities, like less than 10% chance that this is not cardiac, that this is cardiac. So either you have to be female with atypical angina, 30 to 49, or male with non-anginal chest pain, 30 to 39, or female 30 to 59 with non-anginal chest pain. Those are the only low pretest probability patients. Everybody is either intermediate to high. So that's why even without any tests, no EKG, no stress test, nothing. If a patient comes into the clinic or into the ER, and if you're male and if you say that you have chest pain that occurs with exertion and goes away with rest, you have at least an intermediate to high risk that this is coronary artery disease. This is very important. And so low pretest probability is female less than 50, atypical angina, or non-anginal chest pain, males less than 40 or females less than 60, and asymptomatic for most patients, except now we start talking about other risk factors. So if you have diabetes or other cardiovascular issues like vascular disease or carotid artery disease, then you're actually considered high risk, even if you're asymptomatic. So any diabetic that's asymptomatic, we're already classifying them as high risk. So when we do stress tests, the American Heart Association says it's class 1 recommendation, meaning it's most highly recommended to do a regular old stress test. It's class 2B to do an imaging like a nuclear stress test. But you know, when you come to Desert Cardiology Center, we don't do this. We just have everyone do nuclear stress tests. Why is this? It's because what the American Heart Association wants us to do is they want us to do a stress test. And if it's abnormal, somewhat, then we may do a nuclear stress test after that. So it's like a multi-test process that the American Heart Association wants us to do. So especially when you're in the ER, they skip the exercise treadmill and they just go straight to a nuclear stress test or something like that. So that's the provision for class 2B. Class 2B is saying it may be appropriate. The American Heart Association says it may be appropriate to do this. But if you can exercise and if you have an interpretable ECG, they recommend an exercise treadmill stress test for patients with intermediate or high pretest probability of coronary artery disease. And so what is uninterpretable? There's a few things that are uninterpretable, and you can't just do a stress test because you can't read the stress test. And that's people with this thing called Wolff-Parkinson-White, which is a pre-excitation, or ST depression greater than 1 millimeter, or left bundle branch block, or if you have a ventricular pacemaker, or if you have ST changes from left ventricular hypertrophy or digoxin, then we can't do a regular stress test. We have to move on to a nuclear stress test or a stress echocardiogram. And so this is the recommendations by the American Heart Association, and we all try to abide by the recommendations of the American Heart Association, but sometimes there are provisions like class 2B, meaning it's it's there are provisions where we can do a nuclear stress test or a stress echocardiogram. So this is a Duke treadmill nomogram, and I copied this from the American Heart Association guidelines for diagnosis of coronary artery disease. We don't use this. This one is too complicated, but this is what we were supposed to do. We were supposed to get a ruler. And we start with the ruler on how many minutes somebody goes on the treadmill. So if they can go 3 minutes or 6 minutes or 9 minutes, we put a little dot here. That's 1 point. And then there's two other criteria. One is ST segment depression. How much depression is there on the EKG? Is there 1 millimeter, 2 millimeter, 3 millimeter, or 4 millimeter? And then was there chest pain during the stress test? Was there angina? If there's none, you go here. Non-limiting, you go there. You put a dot there. If it's exercise limiting, meaning severe angina, then we put a dot there. So say somebody went 12 minutes, you put a dot there. They had no chest pain and they had no ST segment depression. So what you do is you first get a line here and then you put a dot right here in the ischemia reading line. And then from that point, you draw a line over to how many minutes you exercised. And wherever it crosses the line is the prognosis of this patient into the future. So if they were able to do 9 minutes and no chest pain, no ST segment depression, then you're probably around right here, which means you have a 93% chance you will live for 5 years. That's pretty good. But if you start having chest pain and if there's ST segment depression, then it's somewhere down here where the point you have to put. And depending on how many minutes you do, it lowers the what you have here. And so say you cross at this line here. If you crossed at this line, then you have an 85% chance of surviving over 5 years. If you have chest pain, if you have ST segment depression, and if you're not able to exercise more than 9 minutes. The reason why we don't use this anymore is because it's a little bit complicated. So we came up with a little bit easier way of doing it, and it's called the Duke treadmill score. The Duke treadmill score is the amount of minutes on the stress test minus 5 times the ST segment depression in millimeters, minus 4 times the anginal index. And so it's the same thing as what we were looking at before, but it's sort of simplified. And so from what you get from the stress tests, we classify it as low risk. So low risk is if the score is 5 or greater. Intermediate is -10 to 4. High risk is -11. So for example, if somebody exercised 9 minutes, you put in 9 in the treadmill time. If they had 1 millimeter ST segment depression, then it's 5 times 1. So 9 minus 5. And say they had no angina, then that would be 0. So 9 minus 5 is 4. And so if you had 4, that would put you at intermediate risk. That's how you do it. And so if you have a low Duke treadmill score, then you have a 99% chance that you'll live for 4 years. If you have a high risk score, then you have a 79% chance that you'll live for 4 years. So that's how we sort of classify this. So when people say the test was abnormal, the actual answer is there is no such thing as abnormal. Either the test is low risk, intermediate risk, or high risk. Because even if there was ST depression, so say you went 12 minutes. If you went 12 minutes, and if you had 1 millimeter ST segment depression, so 12 minus 5 is 7. Even if the test is abnormal, you could have a low risk score. And if you have a low risk score, then you have a 99% chance of living. So in that case, we're done. We don't need to do any more tests. You have a 99% chance of living for the next 4 years. But if it's more abnormal, like intermediate risk or high risk, then we need to do something about it. And so this is why it's good to do a regular treadmill stress test, because if we have the fancy injection types, the problem with the fancy injection types is we get the image, but we don't get any of this information on how long you'll live. And so if you're low risk, we're done with testing. We can just treat medically. If you're intermediate risk, then we do a nuclear stress test or a stress echocardiogram. And if you're high risk, then we go straight to a coronary angiogram, cardiac catheterization. PCI means stenting and CABG means bypass surgery. So for stress tests, for doing a nuclear stress test, for example. So if who needs a nuclear stress test for sure, it's for people that have some amount of angina, that are either unable to exercise or have an abnormal EKG where it's considered an uninterpretable ECG, then we go straight to a nuclear stress test. We don't even do a stress test. Or there's other people that need a imaging study, such as prior stents with symptoms. If we know that they have a blockage and we're trying to figure out whether it truly is a significant lesion, then we do a functional significance of a lesion. Or if you're intermediate risk on the Duke treadmill score, then we go to a imaging stress test. So the images look sort of like this on an imaging stress test. It's a nuclear stress test. And so this left ventricle, this pump looks like a bullet. It looks like it's sort of conical. And so the cone, we could either cut into little circles, or if you do vertical cuts, they look like this U-shaped, or if you do horizontal cuts, it looks like another U shape. And so this is essentially a normal nuclear stress test. What you're looking for is a perfect circle around here, like nothing's been bitten out. And so if nothing is bitten out, then it's a normal nuclear stress test. So what do we use as our nuclear isotope? The isotope that we use is technetium. Technetium has 43 protons. And if you remember back to general chemistry, in a nucleus, you have protons and you have neutrons, and on the outside, there's circling electrons. And so technetium has 43 protons. It has 43 protons, and the most stable type of technetium is technetium 98. And 98 is the addition of protons and neutrons. So, but we use something called technetium 99M. So I said that the most stable technetium is 98, but we use something called 99M. This is the band of stability of all the elements. And so this line is a 1-to-1 of protons and neutrons. And as you get to bigger elements with more protons, you need more neutrons than protons. And the most stable ones are on this black line here, this black zigzag line. And as you start getting more or less neutrons, you have nuclear decay. So technetium has 43 protons, so we're about right here. And we're just one neutron more than a stable neutron. So like the most stable technesium is 98. This is technesium 99. And the way that this becomes radioactive is the nucleus, the stands for metastable. So metastable nuclei is a slightly shifted nucleus. The whole nucleus shifts slightly, and it's at a slightly higher energy state. And when it shifts back, it releases a gamma radiation, and then that's what we look for with these nuclear tests. And so this is what we're injecting into your body. This is the half-life of technesium is 6 hours. Thallium used to be 24 is 24 hours, so we're glad we're off of thallium, but this still lasts about 6 hours. And so we're looking for parts of the body that absorb technesium. And so what we use is called technesium 99M sestamibi. What we're looking at here is technesium 99M3PRGD2. As you see here, it does not absorb into the heart. But so technesium can be in multiple forms where it can be absorbed into different parts of the body. And so what we use is technesium 99M sestamibi, and it looks like this. So there's technesium, and then there's all these side chains. And the side chains that we have on there make it from a non-polar substance. The reason why fat soluble is a non-fatty, non-polar substance. And the reason why we need it to be a fat soluble or a non-polar substance is because it has to passively pass through our cell membranes. And our cell membranes are phospholipid bilayers, and these are non-polar. And so once it gets into our heart muscle, our enzymes cut off all of these side chains, and then this technesium is stuck in there. So we have, the half-life is about 6 hours. So we have around 6 hours to take pictures. So we don't need to take pictures right away. We have about 6 hours for the technesium to last in our muscles, our heart muscles. And so this is what technesium 99M sestamibi looks like. And so it absorbs into the heart here. This is a cut of the heart. And so it absorbs into the heart. Some of it absorbs into the thyroid. A lot of it absorbs into the liver and the gut. And so that's what you see here. And so we're trying to avoid reading the liver and the gut. And the way we do that is we wait 1 hour. So after a nuclear stress test, we give patients a snack. And that snack is actually important. That snack helps gut motility, and it's moving the gut, all the nuclear substance lower down the GI tract, and then it leaves the heart by itself mostly, and then you take a picture of the heart. So I know I'm getting technical here, but this is all technical. So you see there's two images here. One is rest images and one is stress images. So the rest images, we can just give the technesium and then we can take a picture. But the stress one, we have to stress the body. So we either do a treadmill stress test, and while you're doing a treadmill, we can inject it, or we give that what we call Lexiscan, which is a substance to get your heart going. So it's like a stress test in a little syringe, and we get your heart going. And patients ask me, isn't this dangerous for the body? You're getting the heart going and you're injecting this. Aren't you going to cause a heart attack? The answer is actually it's pretty safe. And the reason why it's safe is because it's a vasodilator. It's not a stressor. It's actually a misnomer to call it a stress substance. You're not stressing the heart. You're just vasodilating the heart. So you just open up all the coronary arteries. And so momentarily for that 30 seconds, you get that cardiac output up to 5 metabolic equivalents. And then it actually drops the blood pressure a little bit instead of raising the blood pressure like in a regular stress test. So you're just vasodilating and you're taking a picture. And so what we're looking for is those blockages, but like we talked about before, we can only find blockages that are 70 to 80 to 90 to 100%. So anything less than 70%, we cannot see with the nuclear stress test. So regular treadmill stress tests, nuclear stress tests, stress echocardiograms, we're all looking for blockages that are more than 70%. So up till about 20 years ago, that's what we all did, was we just did stress tests, nuclear stress tests, and we could only find 70% blockages or more. Everybody else, we said, oh, you're normal, you have nothing. But there is something. It's just not hemodynamically significant blockages. So this is a blockage. So if somebody has an abnormality, it looks like there's a bite out of a donut. And so that's what we're looking for in a nuclear stress test, is a bite out of a donut. Like a bite here or a bite here. That's what we're looking for, is an abnormal result of a nuclear stress test. Again, here we're looking for, so here it's not a complete bite, but it just looks, you see it looks slightly more less intense here on the bottom part. And then here it looks very abnormal. Here also looks abnormal. Here in the apex of the heart, it looks slightly less intense. That's what we're looking for in a nuclear stress test. So when you have clinical data, like does somebody have angina or not, and you have a exercise treadmill stress test, then you have about a 70% accuracy that you have what you're finding on a stress test is actually accurate. So there's actually quite a bit of false negatives and false positives. But it's enough that the American Heart Association says, that's good enough. But if you add a nuclear, it increases it to about 75%. So that's the amount of accuracy that we have for a nuclear stress test, but that's good enough, because the problem is the heart is deep inside the body. Like it's pretty hard to figure out if somebody has coronary artery disease or not. And so next we have something called a coronary artery calcium score. So in the last like 10 to 20 years, we've developed this thing called a coronary artery calcium score. And what we're looking for is calcium, but it's not really calcium that we're looking for. It's sort of a misnomer. These radiologists, they call it calcium, but you don't really have calcium in your coronary arteries. It's scar tissue that we're looking for. So when you have cholesterol plaque, there's a soft plaque, but then our white blood cells go in and we try to fight it. And when we fight it, it turns into this hard scar tissue, and it turns into calcium. And so here they've injected contrast into the coronary arteries. This is the left coronary artery and the right coronary artery. And when you inject into the coronary arteries, it looks like that. And here there's no calcium. And the calcium that we're talking about is, we're seeing here, these very bright objects here, that's calcium. So when we do a CT coronary artery calcium score, we're looking for the end product of coronary artery disease. So that soft stuff we cannot actually see for on a CT scan. It's that hard stuff that we're seeing. So it's not, that's not even 100%, but what we found is it's pretty accurate enough that we're using it now. And the reason why we do a CT coronary artery calcium score instead of injecting everyone with contrast is the total amount of radiation. I mean, like these days, everyone's getting CTs and X-rays and nuclears, but at some point in time, we needed to try to limit the total amount of radiation. Like you wouldn't want a nuclear power plant in your backyard. Sort of the same with medical. Like you don't want to be irradiated constantly. And so if you do the CT coronary artery calcium score, maybe we wouldn't do it for another 3 or 5 or 10 years because we don't want to irradiate you constantly with radiation. But when you inject contrast and you do a CTA coronary, it sort of looks like this, where you can see the artery. And so it gives you more information, but the drawback is we're injecting contrast and also it's more radiation. So it takes more radiation to do a CTA coronary than just the coronary artery calcium score. So coronary artery calcium scores give pretty good information. And before, we're talking about all these normal stress tests. Well, we thought they were normal, but when we do coronary artery calcium scores, that we could see that they have some amount of coronary artery disease. And when we do the coronary artery calcium score, we come up with a score like 1,200 or 0 or somewhere in between. And so this is actually what a non-contrast CT looks like for a coronary artery calcium score. These are the coronary arteries that come off of the heart. And it's really hard to see the coronary arteries. And so the drawback is we're not really seeing into the coronary arteries except for the calcium, except we're using a lot less radiation. And it's cheaper too. Coronary artery calcium score is a little over $200. If you want to pay for a CTA coronary, it's over $1,000. I don't know exactly how much it costs. So this is a low risk calcium. So there's a little bit of calcium, and low risk is considered up to 100, and high risk is 300 or 400, depending on who you listen to, and that's a lot of calcium. And so when you look at the risk of a patient with a calcium score, if you have a calcium score of less than 100, you have a 0.4% chance of heart attacks or deaths in the next year. So we usually do like a 10-year risk. So your 10-year risk is 4%. 0.4 times 10 is 4%. Versus if you have a score of 400 or more, then you have a 2.4% chance per year or a 10-year risk of 24%. So it's a huge difference. And so when we start finding intermediate or high risk scores, that's when we start treating patients with statins and telling people to eat healthy and exercise. And so the CTA coronary, like we talked about, can look into the arteries. And we're actually looking for blockages at this point in time. And so a blockage looks like this on a coronary CTA. It looks like there's not a lot of brightness going through. We have contrast flowing through here. And this is a blockage on a coronary CTA. And this is a coronary angiogram. And so this is a more invasive test. And that's where we put catheters into your body, either through your wrist or your groin. And then we go all the way up to your heart. And then we inject the contrast dye material and we watch under a live video x-ray camera. And that's coronary angiography, not CTA angiography. It's coronary angiography. And that's where you see the same blockage here. So this is the same coronaries, and You see how it looks so much nicer on a coronary angiography? So when we do these invasive tests, this is still considered the gold standard for finding coronary artery disease. Uh, Despite all this, coronary angiograms are still considered the best way to do to find blockages. The drawback, well, radiation is one, contrast is the other, and plus we have a catheter going into your heart, and so it is more dangerous. The risk is pretty low. It's about 1 to 2% risk, mostly bleeding and such. But when we read off the possible risks of doing an coronary angiogram, it's bleeding, infection, heart attack, stroke, kidney damage, death. That's what we read off every single time. And that's because we're working inside of your heart. And so when they do a stent, same thing. When we do anything inside of your heart, they'll read off the same risks: bleeding, infection, heart attack, stroke, kidney damage, death. And so we do it pretty safely. And I would trust any of the desert cardiology doctors to do an angiogram on me. They do a great job, but it's not without risks. There's a possible small risk for every time you put something into your body. And so that's why we have all these non-invasive tests, like nuclear stress tests, regular treadmill stress tests, CT angiograms, coronary artery calcium score. And so we're trying to figure out if somebody has coronary artery disease without putting something into the body. But if we need to really figure it out, or if somebody needs a stent or a bypass, then we have to do a coronary angiogram to figure it out. And the other good thing is, if you're doing a coronary angiogram at the same time, we can put in a stent if you really need it. So why do we not put in stents for 50% blockages or 60% blockages? And sometimes somebody has an 80% or 90% blockage and we don't put in stents. And the answer is from these studies we've done here in the United States. And there was a study called the Courage Trial from the New England Journal of Medicine from 2007. And we put people into two groups. In both groups, people had angina. And so this is stable angina, meaning they're not having a heart attack. Okay, if you have a heart attack, you need to go to the hospital and get a stent or a bypass surgery. But if you have stable angina, then they put people into two groups. So in this study, they knew that these people had 70, 80, 90%, 100% blockages and angina, but stable. And in half of the group, they put in stents and they gave optimal medical treatment, meaning tell them to eat healthy, exercise, and put them on a statin and an aspirin. So we half got stents and half did not get stents. And what did we find? That people live for equal amounts of time. So if you're a stable coronary artery disease patient, there's a lot of argument to say maybe you shouldn't get a stent if you're stable, if you're completely stable. So when this came out in 2007, a lot of the cardiologists did not believe it because we thought we're saving people's lives when we're putting a stent in a 70, 80, 90, 100% blockage. And so there was a lot of argument on this. And back in 2007, this was considered a poorly designed trial. So the US government sponsored an even bigger trial. And this is a lot of the other studies. So the Courage trial is here, and a lot of the other studies, they all when you put them all together, people live equal amounts of time either with no stent or stent. So they came up with a bigger trial, and it was published at the American Heart Association conference in 2019, and it was published in the New England Journal of Medicine. and it was called the ischemia trial. Same concept. They knew, so they got patients with known anginas, so people with chest pain, but stable, with known blockages. And they were all given optimal medical therapy, but in half of the group they got stents, and half of the group they did not get stents. There was a little bit of crossover. That's what this is talking about. But that was the design. And there was moderate to severe ischemia. So, and this was the eligibility criteria. There was 8,000 people enrolled, and then about 2,500 in each arm. And this study went for 3 years. And again, we found that there is no difference in deaths between stents and no stents in stable patients. But that's not always the case. There's exceptions, right? Because we're all made differently. That's how humans are. We're all made differently. Our situations are different. So then we're trying to figure out, okay, who needs something done or who doesn't need something done. And same. So this is showing again no difference in deaths in the ischemia trial. And so there's certain things which we considered a higher risk. And with all these tests that we do, there's higher risk patients that may need stents because they're considered higher risk of death. And so those are like heart failure patients, multivessel disease in the left main, coronary artery calcium score greater than 400, stress-induced LV dilation, drops in the ejection fraction with stress, wall motion abnormalities with the butymine stress echo, bigger territories. This is talking about bigger territories of the heart having ischemia, ventricular arrhythmias, a significant ST depression, or a significant Duke treadmill score. So there are exceptions to that rule. So we're trying to figure out who needs stents and who does not. But the answer to does somebody need a stent is not simple. It's very complicated. And so when the coronary CTA came out, everybody wanted a coronary CTA. They said, oh, this is the best thing in the whole wide world. Everybody should just get a coronary CTA. But when we do a coronary CTA, we don't know if that is causing harm to the patient. And so what that has caused is for us to do even more tests now. So not only do they need a coronary CTA, now they need a nuclear stress test and maybe even a regular stress test on top of it and an echocardiogram. And so it's brought on even more tests. So do we do all those tests? Maybe or maybe not. But the simple thing is, is it really impacting your life? That's number one. And we do a few simple tests to make sure you're not a high risk individual. But when it comes down to it, when we see these studies, other than for heart attack patients, okay, if you're a heart attack patient, call 911 and go to the hospital because you need a stent or a bypass surgery. But if you're not having a heart attack, then the most important thing is going on medications, eating healthy, and exercising. It's not all these fancy stress tests. It's just a very healthy lifestyle. So with all these complicated tests, it comes back to the most simplest of things, which is if you take care of your body, if you're eating healthy, exercising, taking your medications like your doctor tells you, that is the most important thing in stable coronary artery disease patients. And that ends my talk on diagnosis of coronary artery.
All right, so we'll open it up for questions. Please raise your hands if you're here. Just wait for the microphone to be passed to you. And those online, please leave it in the chat, and Aaron will take care of it. We've got it in the back here.
Yeah, I was just wondering, what's the American Heart Association's stand on using the photon count, CT scan for a diagnostic tool?
The latest placed it into a class 2 recommendation. So it's still not even class 1, but so when it's considered a class 2, it's they want you to consider it, but a CT scan or a photon CT scan or any of those newer ones, there still isn't not a very strong recommendation of that.
In a patient, in a person, in a person who has no chest pain but has a high risk, lots of risk factors, it looked like you would not do or even think about an angiogram unless their CTA showed some abnormality. Is that correct?
Yeah, so yeah, there are some high risk features that we're looking for. So sometimes we do a stress test just to make sure they're not having arrhythmia, significant ST changes, because when that's the case, maybe it is time for somebody to get a stent. And then the other thing is sometimes we need to consider whether they have left main disease. Left main is like the main stump of the whole coronary artery, and if that goes down, then that could be very major. So you could do that with the CT, you could do that with the nuclear, but you have to have that in mind. But outside of that, so if you have a normal ejection fraction, so if you don't have heart failure and if you don't have major ischemia in either history or a stress test, then it may be reasonable to not stent a patient.
Can you tell me what the action of nitroglycerin is? And if you're having a heart attack, should you have access to it and combine it with crushed aspirin? Is that the best until you can get 911 help?
So the answer is nitroglycerin has not been found to save lives. So we've done major studies, and the people that get nitroglycerin during a heart attack and not survive equally the same. It kills pain. That's the main thing. It's for symptomatic treatment, not to save lives.
So, right here, Doc, with the nuclear stress test, though, is part of the discovery with that also symptomatic as well, in addition to the results? So, would you think that if you had symptoms at rest, part of the reason to do the nuclear, or even I guess the regular stress test, is to exert the heart so that those symptoms become more prevalent? And if they're not, is that also, I guess, an indicator of like a low risk result?
Yes, correct. And so that's part of the Duke-Treadmill score. So that has a multiplication factor of 5 because it's important. So it really depends. That really shifts the Duke-Treadmill score, meaning it really shifts if you're high risk, intermediate risk, and low risk. And so, yeah, actually, it's very important.
Doctor, you explained a little bit about ejection fraction. Could you explain a little bit about that? And with newer medications out in the last 10 years or not, can you improve the percentage rate? Will the percentage rate go up with different medications on ejection fraction nowadays?
That was my last talk here at Mended Hearts a year ago, was ejection fraction and medications. But there's two types of heart failure in this world. It's a low ejection fraction heart failure where the pump is weak, and there's regular pump heart failure. And the newer medications have shown that there is an improvement in survival, and we do see an improvement in ejection fraction when we put patients with low ejection fraction with heart failure on medications. Not always, but we do see that quite a bit. So Kate L says, I was told the stress echo are a better test for women. What are your thoughts as long as they can walk and don't have pacemaker or left bundle branch block? Well, stress echo, there's no specific recommendations in the American Heart Association, and the weight is exactly the same for stress echo and nuclear stress tests on the American Heart Association guidelines. The reason why a stress echo may be considered is less radiation because it's using sound waves. But it also, the determination mainly has to do with the workflow of the hospital. And so in certain hospitals, the workflow is stress echocardiograms, and then the workflow is mostly nuclear stress tests at certain other hospitals. But the diagnostic ability, even in women, is about the same for nuclear stress tests and echocardiograms. And the other question is, why do some doctors order a stress test after a calcium score of 10 and the patient denies any symptoms? Well, we're always looking for false positives, right? Like we're looking for the unicorns. That's the thing with medicine, is nobody is exactly the same, and ultimately somebody could have an issue even with no symptoms and a calcium score of 10 is very unlikely. It's like for example, a 30-year-old coming into the ER, how likely are they that they're having a heart attack even though they're having chest pain? But it happens. It's very rare. And so a lot of it has to do with clinical judgment. And so I'm hoping that I won't be replaced by an AI humanoid robot anytime in the next year or two. You know, they're coming. AI. But I think the thing about humans is that we're not robots, and everybody's made differently. And even when we do these coronary angiograms, the way that these things branch off looks differently, and everybody is so different that a lot of it comes down to a cardiologist's decision, like clinical judgment on, do we think this person really has a problem or not, even when they say they're not having symptoms. And so that's what we try to do. We try to be a good cardiologist. We try to be a good doctor. And we try to really figure out, does this person really have an issue or not? And does it really need to be stented or not? And it's, even though there's American Heart Association guidelines and all these flow charts, even with that, there is some amount of judgment that you have to put into. And so medicine is somewhat of an art and somewhat less of a science. And then the last question Kate asks is, these studies are showing same risk for death, but what about quality of life, having chest pain? Yes, sometimes we do put in stents for chest pain. That's one of the American Heart Association guidelines for putting in stent is just for chest pain. But when we put in stents into these people, yeah, it will improve quality of life, but it may not prolong their life. And so sort of, there's sometimes a duality that we have. And so, yeah, there's a lot we have to consider at times.
One more question over here, doctor.
Are statins I guess the question is, are statins therapeutic? So even in the absence of elevated cholesterol numbers?
So,
I didn't know
I did look this up a few days ago because there was a new American Heart Association meeting last week, and they were talking about cholesterol. And in cholesterol, what they found is, I was looking back to this one study. I mean, there's so many studies. I can't look at all the studies, but there was this one study on atorvastatin, Lipitor. And they put one group with 10 milligrams of atorvastatin versus another group with 40 milligrams of atorvastatin. And the death rate decreased by 20% for people with known coronary artery disease. That's pretty good. And so then when we extrapolate that out, we're wondering, how about these people that have coronary artery disease, but they have a normal cholesterol? Well, they have cholesterol plaque in there, but they have normal cholesterol. So should we treat them or not? And I think we should, because what we found is, even when we put people on normal cholesterol on a cholesterol medicine and we drop them down to quite low LDL, like 55 or 40 LDL, which is extremely low, we find that, yeah, it does decrease heart attacks. But, and so then there was this one study that came out this week saying, how about these patients that already have low LDL, so bad, that's the bad cholesterol, and there's all these patients that were on high intensity statins. Should we put them on one of the newer cholesterol medicines, PCSK9 inhibitors? And one of the drug reps came and saw me, and he said the results were fantastic. It lowered the risk by 25%. But when you look, we already have them on statins. And so when you put patients on statins, they're on this study from this week, their risk of heart attacks or deaths was 8% over 5 years. So on a statin, you have a 8% risk over 5 years. And then we put them on these newer cholesterol medicines, which is the injectables, the Repatha. And when we put them on Repatha, every 2 weeks, it dropped it down 25%, but it went from 8% down to 6.2%. So should we do that? I mean, it does significantly lower it, but with all current medications, we're already dropped it down to 8% over 5 years. So do we need to go down to 6.2%? And so a lot of it has to do with risks and benefits, because we're sort of getting into age of polypharmacy. Like, we don't want to be on a lot of medications. Like, I don't want my breakfast to be 10 or 12 different medicines, which a lot of my patients are. But the studies show that it is significantly different. But then at the same time, you sort of have to say, how many medications do I really want to be on? And am I willing to accept all these side effects on these medications, which they all do, including statins, including PCSK9 inhibitors, including aspirin. They all have their possible risks. So that's something we have to weigh. But the simple answer is, it probably does have some amount of effect in lowering heart attacks by putting somebody on a statin, even when they have a low cholesterol, if there's known coronary artery disease.
So I'm sorry, one more question, just a follow up to that, because I know the answer. Can you have a heart attack and not have coronary artery disease?
Most likely not. There's other things that happen that are very rare, but the classical coronary artery disease, no, you need to have cholesterol plaque in there. So there's some people that have spasming, which is quite rare. Dissection of a coronary artery, that's very rare. But the classical heart attack, you need to have cholesterol plaque in there. Broken heart is different. It's not a heart attack.
Dr. Shea, I wanted to ask you what you think the role of low-grade inflammation is with coronary disease.
So, good question. So there's been a few studies involving that because what we've noted is if you have elevated inflammation like CRP and ESR, your risk of heart attack does increase. And so then there's been some studies adding like Zetia to statins to try to lower your inflammation, which had some effect, but again, it's an additive. Like they never get rid of statins. Like they're just adding more medications to statins. And then there was a study from last year which showed that gout medicine called colchicine improves your risk of heart attacks. But that gout study showed that it reduces heart attacks, but it does not reduce death. So what it probably means there is some amount of effect, but not super major effect. And so again, it's like, how many medications do you want to be on? Like after a heart attack, do you want to be on another medication or another medication after that? But there is some effect of inflammation.
I think we're going to end the questions for the night. And I just want to thank you so much for the insight that you've given us. And one other question. At what age should someone begin a relationship with the cardiologist? Primary physician begins, but at what age would you say, or is it age?
It mostly has to do with risk factors. And so do you have family history? Do you have diabetes? Do you have high blood pressure and cholesterol issues? Did you smoke in the past? Are you eating very poorly? Did you do drugs? You know, that kind of thing. And if the answer is yes, then maybe the CT coronary artery calcium scores we could possibly do at about 40 years old, but the consequence is additional radiation for most of these tests.
Beautiful. Thank you all for wonderful things. Thank you so much. We appreciate it. We appreciate Dr. Choe and his insightful information that he's given us. And we appreciate Aaron Green for running our AV program for us tonight. And now we'll support those who are non-members who would like to stay for support and offer advice and tell your story about heart disease. All the members of Mended Heart, would you please raise your hand for us, please? And so now we have lots of members for Mended Hearts around that would be glad to talk with you and answer questions that you may have. So thank you all for this evening.